Good afternoon, one and all. First of all, I would like to thank the NatCon workshop organizing committee, especially Professor Dr. Rakesh Chawla and his team, for giving me the opportunity to discuss with you all regarding some aspects of medical thoracoscopy, including indications, what are the pre-procedural workup that we should do for a medical thoracoscopy, at the same time, what the type of anesthesia commonly we prefer, and what are the agents which should be given and which should not be given. All these things we can discuss in this presentation. As you know that pleural effusion is one of the age-old disease known since the time of Hippocrates, which is frequently encountered condition in the pulmonary medicine field. Approximately 1.5 million new pleural effusions are diagnosed around 1,80,000 thoracoscopies are performed annually, for example, in the United States alone. In Western population, the major cause of pleural effusion were congestive cardiac failure, pneumonia, malignancy, pulmonary embolism, and viral infection. But in India, the commonest cause of exudative pleural effusion in India is still tuberculosis. Thoracentesis provides a definitive or presumptive diagnosis in and around 59 to 73% of the cases, and additional investigations are often needed sometimes. In spite of all the initial fluorocentism investigations, blind pleural biopsy approximately needed in 15-20% of pleural effusion, which remains undiagnosed. Cytological examination is diagnostic in only 60 to 80% of patients with metastatic pleural involvement and 20% of patients with mesothelioma. In such cases, thoracoscopic evaluation has achieved a diagnosis of more than 90% of cases. So, as we discussed, thoracoscopy is one of the very good armamentarium for pulmonologists to diagnose the pleural diseases, particularly when you are in a situation that you are not able to come to a conclusion based on the initial pleural reports. Thoracoscopy can be performed for both diagnostic as well as therapeutic purpose. The most frequent indication for a diagnostic thoracoscopy is pleural effusion of undiagnosed etiology. Even after our basic pleural fluid investigations, if we can't able to come to a conclusion, then thoracoscopy is another very good modality to come to a diagnosis. In case of spontaneous pneumothorax, in order to identify the cause for pneumothorax, thoracoscopy can be used. The most frequent indication of therapeutic thoracoscopy is fluoridesis to prevent the occurrence of pleural effusion, especially in terms of malignant pleural effusion, and any pleural effusions of intermittent origin, and also for staging of pleural lung cancer with pleural effusion, and also for diffuse malignant mesothelioma. Sometimes in heart receptor determination in breast cancer and culture and tuberculosis pleurisy also, we need a biopsy, especially with endoscopic biopsy, especially with the help of thoracoscopy. And staging of pneumothorax, in olden days they used to stage the pneumothorax. We have different staging system. In that situation also we can use this medical thoracoscopy. And certain patients with diffuse lung disease, there are some centers in India who are doing pleural, in addition to pleural biopsy, they are doing a visceral pleural biopsy also. They are doing a parenchymal biopsy also without much of complications. And for this purpose also, we can use the medical thoracoscopy for the diagnosis. And also the patients with the localized chest wall and lung lesions also, we can use thoracoscopy as a diagnostic modality. As I already discussed, some of the main therapeutic indications for medical thoracoscopy is fluoridesis, that stark fluoride in malignant and chronic recurrent non-malignant pleural effusions. Talc fluoride in a patient with a pneumothorax, particularly in patients with secondary spontaneous pneumothorax or recurrent pneumothorax, and patients with extensive septa in the pleura, patients with extensive thickened pleura or extensive septation in the pleura. You can cleave and break the septa, make the pleural space free, and drain the pleural with the help of thoracoscopy, especially in patients with complicated paramyxotion and also in case of lymphoma. There are certain absolute contraindications for doing a medical thoracoscopy. So before doing any procedure, I think all of us should know what are the patients we should not touch ever for doing the procedure. So the first and foremost contraindication is that any condition where there is a compromised pleural space, where you don't have enough pleural space to work for uh, for a thoracoscope to enter and to do a biopsy, I think you should be very cautious to touch the patient before putting your thoracoscope into the pleura. The first and foremost contraindication is the lung that is adherent close to the chest wall, close to the pleura with extensive adhesions, or any patient with severe respiratory distress or with hypercapnia. Definitely, you should not do medical thoracoscopy unless otherwise it will give some positive thing. But anyway, it is definitely absolute contraindication. And uncontrollable cough. Okay, uncontrollable cough is also another absolute contraindication. So, which is sometimes making safe entry and movement of thoracoscopy in the chest will be hazardous if the patient continuously coughs out. And lack of informed consent in a competent patient for any procedure without consent, definitely we should not do any of the interventions in our patients. And unstable cardiopulmonary status. Most important thing is that the patient should lie down. They should assume a lateral decubitus position to see the pleura. Any patient who can't withstand that lateral decubitus position, definitely that patients you should not opt a medical thoracoscopy. And patients with the obvious coagulation defect, a patient with a respiratory failure, a patient with pulmonary embolism, and patients who are unable to who are having inability to tolerate the sedation or allergic to anesthetic medications. So these patients, for these patients, thoracoscopy is absolutely contraindicated. There are some relative contraindications for doing thoracoscopy. One is morbid obesity. Any patient who is morbidly obese, why it is contraindicated? Because sometimes what happens, like in medical thoracoscopy, most of the times we'll use a single port only for the entry into the pleura. And in morbid obesity, you know that, as you know, that the distance from the chest wall up to the level of pleura, it is huge. And sometimes it will be very difficult for us to dissect and entry into the pleura. Sometimes trocar also it will be very difficult to put into the pleural space. So that's why I think it's one of the relative contraindication. But with experience and with all the support of anesthetists and all, so we can even overcome this this problem of entry of this trocar into the chubby patients. As per BTS guidelines, any reversible condition, for example, any pneumonia or any airway disease, should be fully treated before doing the procedure. For example, the patient is in acute exacerbation of any airway disease, bronchial asthma with exacerbation, COPD exacerbation, or any patient with acute respiratory failure, type 1 respiratory failure, or type 2 respiratory failure. All these patients should be stabilized first, and then before taking this patient for thoracoscopy. A caution will be required in patients with certain significant comorbid conditions, particularly patients with ischemic heart disease and also those patients who had a recent MI. Preferably, the procedure should be delayed by at least 4 weeks after initial event of myocardial infarction. As I already described, any patient with a clotting dysfunction, any patient with a chronic renal failure, particularly because chronic renal failure, there will be a vasculopathy. There will be vasculopathy of even the pleural vessels also. When you do a biopsy, what will happen? There will be prolonged bleeding will be there. The risk of bleeding is very high in the patient with a chronic renal failure due to a lot of mechanisms. So that's why it's preferably, better to avoid these patients unless it is specifically indicated to get a diagnosis. And also in patient immunocompromised conditions such as all these things should be addressed before doing the procedure. A high likelihood of tapped lung is a contraindication to do a therapeutic thoracoscopy, as it suggests successful progress is very unlikely. As you know, that trapped and entrapped lung, that whatever you do, the lung is not going to expand. Either it is because of local pleural disease or because of endobronchial obstruction. So there is no point in doing a therapeutic thoracoscopy and doing pleural disease because most of the time it will be a big failure. So we have other option in that group of patients. We have a very good option in our IP, interventional pulmonology, is that putting an indwelling pleural catheter in those cases than this therapeutic thoracoscopy and pleural disease. The known presence of obstructing central airway tumor, which is also a contraindication in such instances. A bronchoscopy without intervention is an investigation of treatment. For example, the patient is having CAO, that is central airway obstruction. Whatever you do, definitely, it won't relieve the symptoms. The therapeutic thoracoscopy along with pleural disease will not be a good choice in this patient because you need to address the obstructive lesions first, and then doing a thoracoscopy and doing a pleural disease. So, what are the pre-op preparation we should do before posting the patients? We should get a well-informed consent from all the patients, and patients are kept fasting for at least 6 hours prior to thoracoscopy. History of systemic illness like hypertension, type 2 diabetes mellitus, cardiac diseases, ischemic heart diseases, any bleeding diathesis, or previous anesthetic complications, history of drug allergies, and any medication history, including antiplatelet and anticoagulant therapy, must be obtained. Very important. Because anyway, most of the times in medical thoracoscopy, the common procedure what we do is a pleural biopsy. Preferably a parietal pleural biopsy, sometimes visceral pleural biopsy, sometimes a parenchymal biopsy also. But most of the time we will do the parietal pleural biopsy. In that situation, we should be very sure that the patient should not have any bleeding dialysis or something. The patient should not take any antiplatelet or anticoagulation therapy. So that history has to be taken before putting the patient into the list of thoracoscopy. And any hypertensive medication will be given on the day of procedure before fasting. Basic blood investigation including total count, hemoglobin, platelet count, blood urea and creatinine and prothrombin must be done for all the patients. Serological investigations for both HIV and HBsAg has to be done as a routine for all the invasive procedures that we do for intervention. Cardiac fitness must be ensured after echo and ECG in most of the patients, particularly in patients who are, debilitated and having a lot of chronic, diseases. So you need to assess their, cardiac fitness with the help of ECG and echo. All patients must have undergone diagnostic thoracoscopies for total and differential cell count, protein analysis, glucose, AD, adenosine deaminase enzyme level, and also acid stain, gram stain, and blood bacterial cultures and blood pressure examination should be done prior to fluoroscopy procedure. That means that you can't do thoracoscopy and biopsy in all the patients, whatever pleural disease you are seeing. Actually, this has to be restricted after doing all the investigation. If you are not coming to a conclusion of if you are in a dilemma, what is the exact diagnosis? Definitely, biopsy is a gold standard for all the pleural disease. For getting a biopsy, the better method is by the thoracoscopy guided biopsy than a blind pleural biopsy that was done in the olden days. All patients should undergo radiological examination of chest, including computer tomography. For this point, there is a different school of thought. Some people used to do a computer tomography to see the pleural nodal location. But anyway, you are going to explore the whole of the pleural space with thoracoscopy. There is no need for that actually. At the same time, computer tomography will give some evidence of parenchymal disease, any nodules in the parenchyma, or mediastinal disease about the airway also. With the CT, we can get some evidence and some points with that. But actually speaking, if we see a massive occlusion and lung is collapsed totally, doing a CT scan, you will miss some parenchymal lesions also. So that's why it's better always to train some pleural fluid and then do a CT scan to get some evidence what parenchymal disease, what type of nodules the patient is having, and exactly to stage the patient also. Definitely, CT has to be done. A focused pleural ultrasound examination, the most important thing. For any pleural intervention, what you are going to do, ultrasound plays a major role. Nowadays, as per the BTS guidelines, it is always better to do a thoracoscopic guided thoracosynthesis, which gives good safety margin for all the pulmonologists for doing the procedure. So, this focused pleural ultrasound examination is to assess the volume and characteristics of pleural effusion, and also to mark the site of pleural space entry. Because sometimes you may see a lockleted pleural effusion, you may get a huge space in some area, you may have adhesions in some area. So before putting a trocar, you should be very sure that you are not hitting close to the visceral pleura, and you should have a sufficient space to work out. So to see this ideally, so you need to focus with the help of bedside ultrasound and mark that with the bedside ultrasound. And after marking, you can put safely your trocar and then work for fluoroscopy. Medication review to ensure the anticoagulants or antiplatelet agents has been appropriately held before the procedure. Multidisciplinary review of cases with the pulmonologist, thoracic surgeons, if needed, if you see any such complicated cases, you can do a multidisciplinary review along with thoracic surgeons. I already told you, you need to take a meticulous history regarding antiplatelet and anticoagulant medications that the patient is taking before posting the patient for thoracoscopy. So what are the antiplatelet medications or anticoagulant medications commonly the patient needs to take that we need to withhold before the procedure? So if the patient is taking warfarin, you should ask the patient to withhold for 5 days. If he is on clopidogrel or prasugrel, 5 to 7 days, you need to withhold. Dabigatran, 2 to 4 days, you need to withhold. Rivaroxaban, 2 to 3 days. Apixaban, 1 to 2 days. Enoxaparin for 24 hours. Fondaparinux for 24 hours. Integrin for IV for 12 hours. Tirofiban IV for 6 to 10 hours. Heparin for IV for 4 to 6 hours. On the same day also, you can stop if the patient is on heparin, and Vivaluridin IV for 2 to 4 hours. So all these things is very important because you are going to do an invasive one, you are going to pinch the pleura. There is always some bleeding risk is there. So it is better to always to stop the anticoagulant based on their half-life, half-life. So if you are using heparin on the same day, heparin biliverdin on the same day, you can stop. If you are using warfarin and clopidogrel, you need to stop just 1 week prior to the procedure. So laboratory cutoff value to minimize the bleeding. These are the points that you should analyze and you should understand. because these are the minimum cutoff level that the patient should have before posting the patient for thoracoscopy to reduce the expected bleeding complication after a biopsy. The platelet should be above 50,000 cubic millimeter. INR should be less than 1.5. Any other pleural diseases, any other pleural interventions, whatever you do, INR should be less than 1.5. And blood urea and creatinine, no cutoff level is available, but still feel creatinine actually more than 2.5, there is an increased risk of bleeding with any procedures. Either with a bronchoscopic biopsy, transbronchial biopsy, or with cryobiopsies, or with a thoracoscopic pleural biopsy, the bleeding risk is very high. That I already explained, because those patients with having uremia, those patients who are having CKD, there are a lot of factors which can lead to the prolonged bleeding. So that has to be addressed. So any patient with higher creatinine level definitely need to be cautious before doing a biopsy. And what are the technical requirements? This procedure must be carried out in a thoracoscopic suit or operation suit. The procedure should be done only by a properly trained interventional pulmonologist. If necessary, thoracic surgeons also can be kept as a backup. A minimum of 2 other suitably trained healthcare personnel are required for assistance, monitoring, and administration of IV sedation. The procedure room must have all the necessary equipments like pulse oximetry to assess oxygen saturation. Non-invasive BP recording also is needed. ECG, continuous ECG monitoring, and resuscitation equipment. Of course, this is one of the invasive procedure. We need to be ready with all the resuscitation equipments, and oxygen source definitely needed. And height adjustable operating table, suction equipment, trolley to hold the instruments, and facilities to display the patient's radiographs. All these things should be there in the thoracoscopy room. That will help the both the patients and the pulmonologists who are doing the procedure. So the instrument what we use is there are 2 things that we are doing medical thoracoscopy. Most of the time it's a single port thoracoscopy. Sometimes we may create additional port, not like a VATS, we do a triple or 4 ports. So we used to put a thoracoscope with a single port only. So most of the pulmonologists are using semi-rigid thoracoscope, that is with the Olympus, that's commonly used. But you can use a rigid instrument also. Single port rigid instruments are very well available. But only thing is that maneuverability and the pulmonologists are very well versed with the bronchoscopy. Okay, so if they use a semi-rigid thoracoscopy, they will be very confident doing the procedure and compared to the rigid thoracoscopy. So semi-rigid is nothing but is rigid only, but the distal part of the thoracoscope is flexible. So you can maneuver the distal part, and you can see the proximal part, distal part, anterior, posterior, and all. You can do that. So that's why semi-rigid thoracoscopy has gained so much of popularity. For example, it has an 7 mm outer diameter and 22 centimeter proximal ridge shaft and 5 centimeter flexible distal tip. It is introduced to a 8 to 10 millimeter outer diameter plastic trocar, which is a disposable trocar available along with the medical thoracoscopy. So biopsy poses compatible working channel usually of diameter 2.4 to 2.8 millimeter. So not this manual biopsy. Nowadays we are very well versed with the cryobiopsies also. So we can do cryobiopsy, not only a transbronchial, we can do a pleural cryobiopsy also, which can give you good chunk of tissue for assessing the histopathology. And a compatible light source video processor should be used for a flexible video bronchoscope for the corresponding link. Bedside ultrasound is definitely must to confirm and reassess the site before doing the procedure. So before touching the patient, once again you reassess whether whatever site you are putting the trocar is really safe enough to work for doing a biopsy. Other procedure preparations as routinely we do for other procedures also. A peripheral venous access must be secured. And prior to medical thoracoscopy, the most important thing is 200 to 300 ml of fluid should be aspirated from the pleural cavity using a needle angiocatheter or thoracocentric catheter. Because like when the patient is having a massive ocean, once you put a trocar, you may have a unnecessary splash of fluid on all this. So it's better to guide it, better to drain it before the procedure so that there will be no fussy movement at the time of thoracoscopy. And patients may be given a prophylactic dose of IV antibiotic. However, there is some difference of opinion in different studies and different guidelines, but patient can be given a prophylactic dose of IV antibiotic 30 to 60 minutes before the procedure. Intravenous promethazine 25 mg stat may be given as a pre-medication, but not necessarily. And patients should be started on maintenance IV fluids on demand. A medical thoracoscopy is commonly performed usually under moderate or conscious sedation in addition to local anesthesia. A prerequisite for optimal sedation drug administered by non-anesthesiologists include a predictable pharmacokinetic profile. It should have a rapid onset of action, shorter recovery time, and overall minimal associated risk. Because we can't ask anesthetists all the time to deliver this sedative. We can only deliver, but what we need is that the safety margin should be wide for a pulmonologist. Okay, so it should not cause, respiratory errors. It should not cause respiratory failure. Or the patient should not go for prolonged sedation. All these things has to be taken care of before selecting a sedative drug. And midazolam remains a preferred sedative drug for, medical thoracoscopy. A sedation is induced by rapidly acting IV benzodiazepine, that is midazolam, administered with a dose of 1 to 5 milligram, approximately around 0.05 milligram per kilogram during the procedure initially. So generally, sedation with midazolam is achieved initially within 2 mg of 2 mg only, and followed by further augmentation dose can be given. Maybe 1 to 2 mg of intravenous doses can be given, depending upon the patient. If the patient coughs too much, if the patient is uncomfortable, if the patient is not cooperating, then you can do 1 or 2 mg of midazolam as an additional top-up dose. An intravenous analgesic agent like fentanyl, 25 to 100 microgram, can be used to titrate according to the patient's pain scale. If the patient is so much, patient complains of so much pain, then you can use the fentanyl also. For additional analgesia, patients receive a total of 50 mg of fentanyl intravenously. A first dose of 25 mg was given before preparation of access site, and second dose before introduction of telescope through the program. Actually, these are based on the studies, but as far as I'm doing thoracoscope for the past 6 to 7 years, but I never used Bethidine just intravenously for this purpose. But this I've taken from some studies. Some studies they have used Bethidine for analgesia. So in case of talc fluorodesis, a total of 100 milligram of Bethidine was regularly administered at the time at the physician's discretion. And good pain control for talc fluorodesis can be achieved by combining opiates and benzodiazepine, as well as anesthesia pleura with 250 milligram 1% lignocaine with spray catheter. Definitely, most of the times with fluorodesis, we use lignocaine also along with the agent, whatever agent used. So that will give a good analgesia, so that after the procedure the patient won't feel so much of pain. Propofol. Some people is for it and some people are against it, because propofol is a very good agent. So propofol is a sedative hypnotic drug. So frequently used in induction maintenance of anesthesia. It's a milky white fluid. Recently, several teams have gained experience with the administration of propofol both during bronchoscopy and thoracoscopy. Initial bolus dose of 10 mg should be given via intravenous route, followed by continuous infusion at the rate of 0.3 milligram per kilogram per minute. And after adequate sedation, the maintenance therapy has to be given at the reduced rate of 0.2 to 0.05 milligram per kilogram per minute is suggested often. Data says that the propofol given for sedation medical thoracoscopy leads to significant higher incidence of hypoxia and hypotension as compared to midazolam. Always, like midazolam comes first. Propofol is on the borderline. Those who are having experience with the use of propofol, those are having an anasthesia backup in their hospital immediately, so they can safely use propofol. But midazolam is more safer, and midazolam doesn't cause hypoxemia frequently when compared to propofol. The propofol leads to hypoxemia and hypotension when you are not monitoring the patient properly. So that needs to be considered before giving propofol. So that's why no studies are against propofol. Propofol should not be considered the first choice of sedation in most of the medical thoracoscopy. And what anesthesia we can use? Most of the procedures, as I already explained, it is a conscious sedation with local anesthesia. We do medical thoracoscopy. A test dose of anesthetic agent of choice must be ensured. Local anesthesia has to be administered, usually lignocaine, has to be administered carefully from the skin, subcutaneous tissue, intercostal muscle down to the parietal pleura. Meticulous admission and local anesthesia of the epidermis, aponeurosis, intercostal muscles, parietal pleura at the entry site assures the patient comfort during the manipulation of thoracoscopy. Actually, rigid thoracoscope will give somewhat more pain, because we need to have a more maneuverability to see the apertures when compared to semi-rigid thoracoscopy. But both are simple and easy only once you know the technique, once you master the technique. But the pain and all the uncomfortable pain will be more with the rigid thoracoscope when compared to semi-rigid. And it is given at the caudal rim of upper and cranial rim of lower rib to anesthetize the intercostal as well as the periosteum of ribs. Local anesthesia is induced by using 0.5% to 1% of lignocaine. Up to 20 ml of lignocaine can be used to achieve good anesthetic effect. The dose of lignocaine should not exceed 3 mg per kg body weight to avoid toxicity, because sometimes there are some rare adverse effects you get after a lignocaine toxicity. Sometimes you may get methylhemoglobinuria, you may get cardiac related adverse effects also is there. So that's why always you should be very careful that dose should not exceed 3 mg per kg body weight. And lidocaine combined with 1 lakh epinephrine may aid visualization by preventing blood from oozing onto the thoracoscope during the procedure. But this school of thought is not well supported, because once you use the lignocaine along with the adrenaline, there will be vasospastic action will be there. The bleeding will be very less. The tip or the blood that oozes from the pleura doesn't encroach the tip of the thoracoscope, so that it won't affect your vision. But this is not the problem in semi-rigid thoracoscope. Often when you use a rigid thoracoscope only, you will get that fogging will be there. So see, already TOCAR is there. Once fogging is also there, you can take out the telescope and you can dip it in any betadine or any saline, and then once again very well safely insert into the TOCAR. So that's not an issue. So general anesthesia is preferable in some situations such as idiosyncratic allergic reaction to local anesthesia, already known patients, or any very anxious patient, uncooperative patient, including children. Most therapeutic VATS procedure, preferably done by surgeons, thoracic surgeons, are performed with patient under general anesthesia. So at the end of this presentation, you should understand that pleural effusion of undiagnosed etiologies is the commonest indication for doing a medical thoracoscopy. All patients must undergo basic hematological and serological investigation before pushing the patient. Midazolam is the preferred choice of sedation in thoracoscopy. Lignocaine is a local anesthetic agent commonly used. And general anesthesia reserved mostly for VATS and special circumstances only. We don't prefer general anesthesia in most of the patients of medical thoracoscopy, particularly single port thoracoscopy. By and large, medical thoracoscopy is a very safe procedure under trained hands with a high diagnostic. Thank you. Thank you, one and all.